So we're getting a presentation from Sonya Grewel. Since 2006, Sonya has been a genetic counselor in the genetic program at North York General Hospital. Sonya received her master's in science degree in genetic counseling at UBC. Sonya provides genetic counseling in the areas of prenatal, HD, cardiac genetics, and colon cancer. Currently, Sonya is the coordinator of the multidisciplinary clinic at North York General Hospital, and we love multidisciplinary clinics. That is so part of our vision and so part of what we really think is critically important, but I get off track. The HD clinic has been at North York General Hospital for approximately 18 years and provides support for patients and their families over the progression of the disease. After Sonya's presentation, we have the advantage of a couple of individuals that have been through the process so that you can ask some questions. So they're very generously offering their time. I'll get to that after Sonya. Sonya, welcome and thank you.
So what I'd like to do today is give you a very brief information about genetics of HD. I know there was a talk from one of my colleagues yesterday that went into the genetics of HD in a much more thorough sense. But in case some of you had not gone to that talk, I just wanted to make sure we're all on the same page before we talk about the different reproductive options. And then I'm going to talk about not all reproductive options. Obviously, the majority of this talk is on PGD and IVF, but I will briefly just discuss prenatal testing, diagnostic testing options as well. I won't go into egg and donor sperm or adoption. And then, of course, through the process, talk a little bit about some of the decision-making processes, some of the pros and cons of each of the tests. Okay, so just again, a basic genetics background. This is a picture of our chromosomes under a microscope. And chromosomes are basically what contain all of our genetic information. They tell us how we're going to grow and develop, what color eyes we have, how our muscles move. We actually have 46 chromosomes, 22 pairs, same in women and men. The differences are sex chromosomes, 2 X's in a female, X and Y in a male. The gene for Huntington's is on chromosome number 4. So just like we have one chromosome 4 for mom, we have one HD for mom, one HD gene from mom, and one HD gene from dad. And so we all have these genes. As long as they're working properly, you don't get symptoms of Huntington. The gene for Huntington's is basically a gene is a combination of letters that make up a sentence in a paragraph. And it's for Huntington's, there's a specific 3-letter code called CAG that's repeated over and over again in this gene. It's sort of like the word and in a sentence. And as long as that word and is repeated just a few times, you can still read the sentence properly, the instructions are read properly. In the HD gene, CAG repeat again, the longer the repeats, under 27 repeats, it's a normal set of repeats so you can understand. The gene can do what it's supposed to do, read the instructions properly. It's once the gene gets over 35 repeats that an individual gets symptoms of Huntington's. So an individual who has tested positive for this HD gene has one basically working copy of the gene and one gene copy that's not working properly, and therefore will get symptoms of HD in the future. It's inherited in a dominant fashion, which means that, as I said, we have one copy of the gene not working, one copy of the gene working. Every time we have a child, we only pass down one of our copies, and our partner passes down the other copy. So I would either pass down the non-working copy, or a 50% chance to pass down the working copy of the gene. So every time I have a child, it's a 50-50 chance. And we see lots of families with lots of combinations, and again, it's all about probabilities. So we see families with all their children affected with Huntington's, none of their children affected with Huntington's. It affects males and females equally. So some families will come in and say, well, only the women in the family get Huntington's. Well, based on what we know about the HD gene, that's not true because women and men both have 2 copies of the HD gene. Okay? So that's a very quick synopsis of the genetics of HD so that we're all on the same page. Now about reproduction. So obviously decisions about whether or not to test a pregnancy for HD can be very difficult for families and couples. And some couples choose not to test a pregnancy, and others decide to test a pregnancy for HD, and there's different options, as I mentioned. One, of course, is prior to pregnancy, so through PGD, I'll say PGD, but that stands for pre-implantation genetic diagnosis. It's a mouthful, so we're going to refer to it as PGD throughout the process. And then the other possibility that I want to talk about is during pregnancy, doing a test called an amniocentesis or a chorionic villus sampling. So I'm actually going to start with the during pregnancy and then move on to PGD. So, as I mentioned, the two prenatal testing options, and I'll go into a little bit more detail in a few minutes, but generally there's two main differences between these tests. The amniocentesis is done later in a pregnancy. It's after 16 weeks of gestation, and the risk of miscarriage, miscarrying a normal healthy pregnancy, is 1 in 200 to 1 in 400. The chorionic villus sampling, or the CVS, is done earlier in a pregnancy, so between 11 and the end of the 13th week of pregnancy, and the risk of miscarriage is slightly higher at 1 in 100. Basically, both these tests are looking at the CAG repeat size in the DNA of the fetus. So they're both doing the same thing, they're just done at different times in the pregnancy. We have a lot of couples that we're not planning a pregnancy, and obviously sometimes when you don't plan, you find out this information, and we try to get them in as soon as possible so they have all their options available to them. So just generally, the amniocentesis, and I should have asked, it's a picture kind of, hopefully nobody's afraid of needles or anything and people are sitting. We do have couples that come in that do faint, so I should have warned you ahead of time. So basically, the amniocentesis is ultrasound guided. There's an ultrasound on where the baby is the entire time. There's a needle that goes through the mom's tummy into the fluid around the baby. In that fluid is the amniotic fluid. And there's just cells that have naturally come off the baby. Just like if you're in the bathroom shower, our cells are coming off, we just don't see them. They take about a tablespoon of the fluid, grow the cells up, and look at the baby's DNA. The CVS is slightly different. As I mentioned, it's earlier on in the pregnancy, and there's actually not enough fluid around the baby to take at that point. So what they do instead is they use a catheter to take a sample of the baby's placenta. So the cells that make up the placenta also make up the baby. And so they do the same concept, is to grow those cells up and to look at the baby's DNA. So these two tests are both done during a pregnancy. There are time limitations. Every province has their own rules, but across Canada there's no indication of when you can, there's no laws governing when you can end a pregnancy. In Ontario and most other provinces you can end a pregnancy up until 24 weeks. And outside of the 24-week time frame, you can end a pregnancy in the States. Here in Ontario, we'll pay for all the medical costs, not the traveling costs. The reason I mention that is that we know that international guidelines for Huntington's testing don't recommend testing for HD in children unless there's concerns that the child themselves has symptoms. So prenatal testing is not done if the couple plans on continuing the pregnancy. And so we have a discussion with them that no matter what the outcome of the test, that if the test is positive and the pregnancy has Huntington's, they would be ending the pregnancy. And so that's why I mentioned the time in which that's available in Ontario and Canada. Obviously the idea is that the children should be allowed to decide for themselves if they want to be tested for Huntington's, and so hence the guideline to only have the test if you plan on ending a pregnancy. And we do have these lengthy conversations with families that come in so that they're aware of why we're offering this and what the plan is. Yes?
Have you ever had anyone that does not want to end the pregnancy, and how do you handle that?
Yeah, so we obviously can't force somebody to end a pregnancy.
Right.
We've never had the experience of somebody changing their mind afterwards, to be honest. And it might be because we go through such a thorough counseling session beforehand, explaining why we're doing this, why we're offering this, why we don't suggest they continue a pregnancy, and what some of the effects are of knowing that your child will have Huntington's and not knowing what to tell them and not telling them. It could be 20 years, 30 years, 40 years. And so we go through a really long session, lots of information. And to be honest, most people coming in at this point, they've already thought about all this process, and they've already made that decision that this is why they're doing it, this is going to be their choice. So we haven't had the experience of anybody deciding to change their mind at the end, but it's always possible, that's for sure. So that's, as I said, prenatal testing that's available. Obviously, what the talk is majority on is the pre-implantation genetic diagnosis, or PGD. Sometimes it's actually called PGS as well, or embryo transfer. There's different names in the literature that they use to describe this. And it's basically for couples that want to avoid having a child that inherits HD, but they don't want to do prenatal testing, and that's when they consider this. So just a little bit of background about PGD. It is basically referring to testing that's performed on embryos created through in vitro fertilization, or IVF, before pregnancy. It was developed in the UK for humans in the 1980s as an alternative to that prenatal diagnostic testing of the amniocentesis and CVS. And of course it was developed to allow couples at risk of passing on not just HD, but other genetic diseases as well, to have children free of the disease. And so we know that it's available for families with Huntington's. This is a very general picture, and I'm actually going to go through each of the processes. The IVF procedure actually is the majority of this. The only exception is that one area of PGD. So what I'd like to do next is actually go through the IVF process and the explanation without the PGD process, and then tell you where the PGD process comes into play at that point. So we'll start with IVF and then introduce the PGD and where it occurs. So the IVF process is basically broken down into 5 steps. The first is, of course, monitoring and stimulating the development of healthy eggs in the ovaries. You then collect the eggs, secure the sperm, combine the egg and sperm together, provide an environment for fertilization and embryo growth, and then transfer the embryos into the uterus. So I'm going to actually go through each of these steps in a little bit more detail, and then we'll go to where the PGD process starts. The first is, of course, monitoring and stimulating the development of the healthy eggs. And this is done through fertility medication, hormones that are used to control the ovulation process and trying to get multiple eggs during a woman's cycle. And it's called ovulation induction. A lot of these medications and hormones treatments, some are covered by individual medical plans, and it's always good to find out about that before you go through the process. You know, what the costs are of the medication, but also what costs are covered, how much in a year, and so on, just so that you have a gauge of other places you can get funding from. Obviously, we want multiple eggs because some of the eggs that we retrieve won't develop and we can't use them for embryos, and therefore you don't want to have to keep going back in just to get a few eggs. You want to get as many eggs as you can, hence the fertility medication, the hormones to stimulate those eggs. The egg development is monitored using ultrasound to examine the ovaries, blood and urine test samples to check hormone levels, and that's all through the process of making sure that we can retrieve the eggs. The second, of course, is to collect the eggs. The eggs are retrieved through a minor surgical procedure that uses ultrasound imaging, basically with a hollow needle through the pelvic cavity. There is sedation, local anesthetic that's used to remove any potential discomfort or pain. The eggs are removed from the ovaries using this hollow needle, and the procedure itself is called follicular aspiration. Some women will feel cramping, a feelingness of pressure. Every woman is different in terms of their own pain tolerance as well. And so sometimes it just lasts a day or two, and for some women it lasts weeks. So again, getting to know and understand through the clinics that you use to see what other people's experiences are, and that will help gauge how things are going for you as well. Third step, of course, is to secure the sperm, and that's done through ejaculation, and it's prepared to combine with the eggs. The fourth is where it gets a little bit more complicated in the IVF procedure, and this is when you're basically wanting to combine the egg and sperm in the laboratory, provide the proper environment so this embryo can then grow. The process is called insemination, and in some IVF programs, they allow the sperm and the egg to fertilize on their own to create an embryo. When we use a PGD process, they use a technique called ICSI, or cytoplasmic sperm injection. And basically the picture, what it's showing is that you've got the egg and they're going to inject the one sperm into the egg for fertilization, as opposed to allowing different sperm fertilize the egg. And the reason for this is that by doing this, you eliminate any excess DNA that's contaminating that embryo. Because remember, we're looking at the DNA for the PGD process, and so any contamination would give you incorrect results. Okay? So that's important for fertility clinics to let you know that they're using this procedure. Mostly because there has been some literature that using this ICSI process, so actually injecting the sperm into the egg, has other ramifications, and those are other general chromosome problems that can occur, 50% of which are thought to be sex chromosome related. So there are some other abnormalities that the literature suggests may occur in that embryo outside of the whole HD testing process. So it's important to ask the fertility clinics if that's the procedure they're using, what their risk numbers are, and their experience with that as well. As I said, the literature is a little iffy because the original research done on this ICSI procedure was done very long ago when a lot of couples were going in for treatment because they didn't know why they couldn't get pregnant, and testing on each individual's, each of the couples was not done to determine why the infertility was there. So one of the parents may have actually had another chromosome problem that they were bringing into the embryo, but they weren't testing that at that time. So hence the literature is a little bit unclear and not substantiated yet. So this is actually just what happens is once the fertilization occurs, the eggs are actually monitored to confirm the fertilization and cell division is taking place. So you just see how the cells are dividing here. And then once the fertilization occurs, they're now considered embryos. And then, of course, the last stage of IVF, remember, we're not doing PGD at this point. The embryos that are then transferred into the woman's uterus about 2 to 3 days following egg retrieval. At this stage, the fertilized egg is about 2 to 4 cell embryo, and it involves, again, just basically a speculum inserted into the vagina to expose the cervix. It's important to know from your clinic the number of embryos that are being used to put back into the cervix. So majority of clinics will use approximately 2 to 3 embryos, and that's to reduce the risk of multiples, because some people might say, oh, multiples is great, I don't have to get pregnant, but it's also a risk to the woman to have multiples, and therefore there's a limitation in terms of how many embryos they want to implant back in. But it's important to ask the clinics how many embryos they would be implanting in at that point. Okay. So that was the IVF process, just generally without the PGD process. The PGD actually occurs once they combine the egg and sperm to create the embryo, but before we implant it back into the uterus. So, as I said, PGD is after fertilization of the egg and the sperm. The embryos are formed and continue to divide into multicellular entities. On about day 3, and of course all these days are a little bit, they try to do it as specifically as possible, but again, important to ask the clinics each of these questions, after day 3, the cell's at about 6 to 10 cell stage, or the embryo's at a 6 to 10 cell stage. And the embryo is basically prepared at this point for a biopsy process in which they're actually taking a single cell out of the embryo, of the developing embryo for genetic evaluation. So this is just a very brief picture of it. It's just the technique is very challenging. It's very small, and they're basically removing the one cell from the embryo using a special microscope and micromanipulators. And basically the goal is to remove the one intact cell with minimal trauma or damage to the remaining embryo. Because what they do is they take that one cell out, and they're going to let the rest of the embryo grow while they're testing this one cell for HD. Okay? If they destroy the embryo at that point, it doesn't matter what that cell contains, they can't use that embryo to implant back in. So as I mentioned, the rest of the embryo's back in for growth. We take the single cell to test for HD. One of the limitations of a biopsy is that, remember, the cell is about 8 cells. The embryo's at about 8 cells. We're just taking one of those 8 cells. Our assumption is that that one cell, the DNA in that one cell is identical to the other 7 cells. So the genetic test result from that one cell is equivalent to the rest of the cells. There can be cases of what we call mosaicism. And that's when, in an embryo of those 8 cells, you can have a mixture of cells, some with one result, some with another. It doesn't happen very often, but it is one of the limitations of this because we're not looking at the whole, all the cells in the embryo, we're just looking at one of the 8. So, before they even get to the process of testing the embryo, the prior to the IVF process, the lab actually coordinates with the couple, and there's a lot of things they're going to talk about. They're going to give you a full explanation of the process, including the accuracy of the test, the turnaround time, and how they're testing for that HD in the single cell. And it can be done through two different types of tests. One is through something called a linkage analysis, and one is through sequencing. And it can get very complicated. I'm going to give you a very brief description of both because depending on which technique they use, the amount of information they need to gather before your IVF process can vary. So one of the ones that, this is not the one that they most often use, but this is the one, sequencing is when we have our blood taken to look for the HD, if we have the repeat or what the repeat size is, they actually look at that gene and they actually count the number of repeats to see what that count is. So it's what we call almost like, in simplistic terms, it's direct sequencing. You're looking at those repeats within that gene. Sometimes when you do that with a very expanded gene repeat or with limited DNA, what can happen is that we have two copies of these repeats, one from our mom, one from our dad. But what can happen sometimes is when they're using the technology to look at those repeats, one of these genes drops out, and you actually only get the result from one gene, which can give you a false negative result in that embryo. The technique becomes a little bit more complicated for the embryo versus if we have our blood taken because of the quantity of DNA and the technique that they're adjusting to for the limited quantity. So they often don't use this type of technique when they're using when they're doing the PGD testing, so the testing on that single cell. The one that they more often use, and again, this is important to ask the clinic that you're using what technique they're using and why they're using one over the other. The one that is more often used is something called linkage analysis. And basically, in linkage analysis, you're not actually looking at the repeats or that specific gene. You're actually looking at markers around that gene. And the idea is to see if that embryo contains markers that go to the lineage of the affected family member. And so they're really, it's kind of like flags in a golf course where you're just tracking them to see is it this golf course or this golf course. So you're looking at, is this gene in the embryo coming from the line that's affected with HD or from the line that's unaffected from HD? When this happens, when you're using linkage analysis, just because you're looking at a lineage and not just the parents involved, you actually need more samples than just that of the parents or the couple. So what happens is that if you're using linkage analysis prior to the PGD process, they're going to talk to you about needing blood samples from more than just the couple involved. They're going to need samples from other family members so that they could look at these different markers so they can trace the lineage when they're doing the embryo testing. In a sequencing situation, you would just need the couple to know what repeat size you're looking. But in a linkage situation, you need much more information prior to starting the process. It's a very brief description of both processes. It can get quite complicated, and if anybody has more questions, I'd be happy to answer them afterwards to clarify some of it. But the main reason I mention it is that prior to the PGD process, they're going to want to gather different amounts of information based on which test they're doing. And again, both tests are basically determining whether the embryo contains the HD gene from the affected parent. So the ultimate idea is the same, it's just the accuracy of which test they want to use.
So I guess there's probably changes like from clinic to clinic, like their success rates and stuff like that, but overall, could you say that, like just from what you said, is this one more successful
Yes.
than the previous one?
Yes, absolutely. So I think originally, it was actually, so I myself don't work in a lab, so I've been trying to contact labs to get more information from what they do. And surprisingly, that everybody in my office actually thought we still did the sequencing. So originally, they started off with the sequencing. And I think what's happened is through their experience, they realized that this gene gets knocked out, or not knocked out, but it doesn't get identified, and therefore this linkage is a better option. Now, this test is not new. Linkage analysis is not new. It was actually what they used to do before we discovered the gene for Huntington's. So this is actually originally where we started using this. We've just found a different purpose for it now. Yeah?
It takes several weeks, so when in the process does it actually start for you?
So this starts even before the IVF begins. So before the IVF process, you're meeting with the clinic. They're going over all the information, how they're doing things, what the time frame is, what samples they need. They collect all these samples, they run all the tests they need to, and only then would they start the IVF process. So this is all done before. The reason I mentioned several weeks is sometimes, you get this idea that, okay, this is what we want to do, we're going to go in, we should be able to do it right away, this is our plan. And people are surprised that it's not so quick. You have to actually wait. You can't just wait for the woman's next cycle. There's all this testing that needs to be done beforehand. But none of it starts without, because once you start the process, you don't have time to do this. And the turnaround time is much more quickly, and you need everything in place prior to starting. Yeah?
So I actually have a question. I don't know, maybe it's coming in, but these are all like the egg side of it. If the males deposit one, is there like a artificial insemination route you take, where you just take his sample and then you don't have to take an egg at all?
Right. So what happens is that it's regardless of whether it's in the sperm or the egg. What happens is these are embryos that are combined, the egg and sperm. So it doesn't matter whether it's for the father side or mother side. Once the embryo is formed, you have the genetic information for both mom and dad at that point. It's just that we talk about a little bit more about eggs because the gathering of the eggs is a little bit more tedious than the sperm at this point. Any other questions before we go?
Is your question though that can you do something with the sperm?
Yeah. Like,
Oh,
could
just testing on the sperm.
Could you
Okay.
just say
Yeah.
clean up the sperm sample
Before you even,
and then
okay.
inject it into
Sorry,
the
yeah.
rather than pulling
Yeah.
the egg?
No. And so what happens is if they do the testing on the sperm, well, the only way to, so you'd have to do the testing on the sperm individually and then allow whatever process to take place. If you do the testing on the sperm, you destroy the sperm. So you can't actually use it. Same thing with the eggs. You can't actually just take the eggs, forget about the sperm, and test the egg itself because you destroy the egg. It's only by combining it, making an embryo, letting it grow, taking the one cell out, that you are able to then test. So sorry, I didn't even think of that, but you're right. Yeah, you can't test the sperm or the egg independently because then it is not, you can't use it for fertilization. Yeah.
So you think about that one cell, you want to reduce the amount of damage to the other cells.
Yeah.
Is there a threshold, and what are the implications if there is damage that is near that threshold? What kind of deformity or what kind of-
Yeah, I don't know all the specifics, but my guess is actually what happens is if they damage that embryo, remember while you're doing that test on the single cell, that embryo is going back to grow. So it's still supposed to be multiplying and dividing. If it's damaged, it's not going to do that. So when they decide, oh, this cell, it looks good, it's negative for HD, let's use the embryo that it came from. And if they go to that embryo and see that it hasn't grown, it's been damaged. And so I'm sure there's much more specifics that they're looking at, but the general thing is that if it's damaged, it's not damaged in the sense that it changes part of the DNA or chromosome, allows it to develop, and then you implant it, and then you see the damage. It's the damage to the embryo actually continuing to grow and being able to be implanted. Yeah?
When they test the embryo, do they also test for other chromosomal deficiencies?
So it's a good question, and a question that you should ask the fertility clinics. There are other tests that they can do. One is one more common that we hear about is age-related risk. So we know as that women get older, there is a risk for chromosome problems to increase. And they can test for some of the more common chromosome problems. They won't just do a blanket test of everything, but let's say you have a family history of Huntington's, but also have a family history of CF or cystic fibrosis. You could talk to them and they could test for those. I did ask the lab how many different tests can you do basically, and you can't do hundreds, but you could probably do maybe 10 to 20 depending on the test involved. And with technology growing, that number may change. So there is some limitation on how much you can test, but they can test for more than just the HDG. Again, this is something you'd want to discuss prior to going through the process, so you know exactly what they can and cannot test for. So, and then of course, non-affected or normal embryos are then transferred into the uterus for implantation. So that completes the IVF with the PGD process. There's obviously many challenges to the PGD process. Of course, even with the successful IVF or PGD procedure, a pregnancy is not guaranteed to go to term or near-term delivery. And as I said, removal of a single cell without breaking or causing serious damage to the embryo. I found on some of the labs that I use, the lab that we use gave me a risk of about 0.1%. Of damaging the embryo when you remove that one cell. Again, something you'd want to ask each fertility clinic in each lab because it probably varies. And then of course, even once you get a large number embryos put together, there may be a large number that are abnormal, and you may only have few to no healthy embryos to implant back into the uterus. So those are some of the limitations and challenges. Of course, additional challenges are cost. It's quite expensive. Again, it varies from clinic to clinic, and very important to get the specifics of what the cost entails. How many eggs are they retrieving? How many embryos are they making? Can they freeze the embryos for you if they find some healthy ones for future use, so you don't have to go right to the starting point? So these are all questions you want to ask with that cost, what it entails. The success rate, unfortunately, is quite low. They say it's getting better, but it's only getting better slowly. It's not 100% at this point, obviously. The only place I could find some good pregnancy rate numbers was through the Canadian Fertility and Andrology Society, which collects statistics voluntarily from clinics across Canada. And there's about 28 clinics across Canada that I found that will do PGD. And the IVF pregnancy rate was about 32%. Majority of those, not majority, but a large proportion, being 24% of those 32 multiples. And the 32% is implantation success, but not birth. So the percentage of IVF pregnancies that go to full term and delivery is a little bit lower than this, and it's probably about 26 to 28%. So it's important when they're giving you numbers to understand where those numbers are and what that means. Is it just the success of implantation? Is it the success of a full pregnancy and whatnot? And you'll find that most of the fertility clinics still recommend that you do a diagnostic test during the pregnancy. And it's usually the amniocentesis because of the lower risk of miscarriage at that point. Okay, so they're still suggesting you do this test. Now, it doesn't mean that everybody does it, but they're covering their own basis by telling you that you should do the amniocentesis to confirm that indeed we've selected an embryo that's unaffected. So in Ontario, I didn't look at across Canada all the clinics, but in the GTA area, there's actually 5 clinics, IVF clinics, that work with a lab, specifically the Genesis Genetics Institute in Detroit, Michigan. So a lot of the information that I gave you is actually from this lab specifically. So as I said, it can vary from clinic to clinic and lab to lab, and so it's important to note what the different steps are for each of the clinics you're using in each of the labs to ask the right question. The last thing I just wanted to talk about is something called nondisclosure PGD for Huntington's. Basically, nondisclosure means that we know that 50% people at 50% risk of HD don't always want to know what their status is. So they don't want to have a blood test themselves to know what their repeat size is. But they still want to, they're still concerned about passing on the expanded gene to their children, and they still want a method of preventing that. So there is what we call non-disclosure PGD, where you can actually get the PGD process done without knowing what your status is. It's a lot more difficult, but it can be done. And basically, they will, in a general sense, they'll look at yours, they'll take both partners' blood samples, test them for the repeat size, find out if the individual from the affected side of the family has an expanded repeat. They won't tell you, but then they will do the PGD process through that and implant the embryo, the non-affected embryo. But it's important to remember that sometimes when they test both partners, they find that both of them are normal, meaning that neither has, or the one that is from the affected side of the family is not going to get HD. They have a normal repeat number of the HD gene. They're still not going to tell you this, though. So they're still going to pretend they're going through the PGD process and the IVF process because they're going to plan this all ahead with you and not make any changes to the plan, because if they do, you now know your status. So it's important to, there's a few little tricks that they use in order to allow non-disclosure PGD testing, and if that's the case, it's really important to get that information from your clinic on all the specifics of what they do or don't do to make sure that you don't get information you don't want. Yeah?
The cost is still the same, right?
Yes, yes.
You could save them $20,000.
Minor detail, yes. Yeah, so the cost is still the same, they are just not actually doing it. Yeah?
I just have a question about the cost. For me, PGD is something that I'm interested in.
Yeah.
And I mean, the cost, I don't really think about it because it's really priceless to me as a child without HD. But I know somebody who's about to start the PhD process, and she was told that she can actually claim some of the amount on her taxes. I don't know if you're able to confirm that, or because I had never heard of that, so I just wasn't sure.
And this is in Ontario?
Yeah.
Okay.
Yeah.
So there is a possibility. It's hard to say. Mac, are you in Ontario?
No, Alberta.
Oh, Alberta, okay. So what you can do is, in Ontario, you do have a certain amount of that you can claim for medical expenses that are above and beyond any government-funded processes. I don't. If that's the case, then they don't have stipulation that that's not a medically funded thing. So as long as it's within that realm, I think after you hit $1,500 or so, you can claim some of that. You don't get all of it back, but you get a tax break on it, and that's very possible. It's something to look into. I haven't had any couples talk to me about that yet, but that might be something that is available. Yeah.
What if the embryos that you pull, what if they're all infected and you're going to do this non-disclosure? How do you deal with that?
So they also have a process for that, and they basically go through the process and pretend they implant an embryo. So a lot of this pretending occurs, but it's all organized pretending in a sense. So yeah, if there are no viable embryos, they will again go through the process as though they're implanting an embryo, but not tell you, and just basically tell you in the end that it didn't implant properly and there's no success, which is not uncommon with the PGD process to begin with. It's just that they've already know what's going to happen in that case. Yeah.
Is the cost, so you have to pay again if none of the embryos?
So if none of, yeah, so not just in non-disclosure, you mean in general?
Yeah, in general.
So yeah, if you get no embryos or the embryos implanted, none of them take to a pregnancy, you have to start again. And the cost is for one cycle, meaning one process. And this is why it's important to ask the clinics that you were talking to if any of those embryos are frozen. The success rate of that is still not great, but if that lessens the cost, and maybe you had lots of eggs and lots of embryos, it's different for each case-by-case situation, but that's important to remember, because if you don't have to go right from the beginning, you might have a less cost, but you do. It's just for the one cycle. Yeah. Okay, just right behind you. One second. That's it.
So the pretending one.
Yeah. Hate the word, but
They'd
it's
be
true.
obviously using some contraception of some sort. So how would you, they're doing it naturally then, right?
No,
Oh,
no,
so
everything
still
is within.
Okay.
So they do everything like outside of the uterus. Everything's been
Okay.
done. They just pretend to do the process. They see the embryo. They get you in. They implant. So everything is done outside, just like it would normally. Did you have a question?
Yeah, with IVF, I know in the past, the government put some standards on it, but you can only do it like, say, 3 times. Is that still the case, or because of the specialty of HD, you can try as many times as you financially can afford to?
So you can actually try as many times as you want.
Okay.
There's not, I don't know where the stipulation was, if it was because of the medications used or not, but
Because the government was paying for part of it before.
maybe, and that's
No,
why.
I don't think
is
the
that,
government has ever.
it's never paid for, right?
No,
So
we
I
paid
don't-
full.
Yeah. So I don't know why the stipulation.
The stipulation was how many eggs they could have.
Yes, that, yeah. But it
There
could
was
be.
that stipulation, but I think
What-
this is a long time
what
ago.
province are you from?
They did put some limits on there, how many times you could.
And is this in Ontario?
Yes, it's
Okay.
Ontario.
So it may have been, remember IVF is starting to have been around for a little longer now. When it first came out, I don't know the rules that were there when it first came out, but based on the information I have now and the fact that the government's not funding it at all, that there's no stipulation on how many times you could do the process. There's no harm to the individual per se. Now, as I said, for every case is different. Can there be some side effects of the fertility or other medications that clinic might limit it for a reason, or within a certain year or something, or time span? I don't know about that. It's sort of beyond my scope, but I don't know of any rules or regulations where the government would stipulate it. They did, however, stipulate how many embryos that you could implant, which again, province to province, country to country can vary, and important to know how many embryos you implant. Yeah.
So my question goes back to the non-disclosure. That's pretty much something that I'm interested in. So I was trying to do some research and try to find clinics in Canada that do it, but it's been my experience that virtually no clinics want to advertise that they do it. And if you call them, they kind of give you a very good answer. So I guess my question is, like, how do you find out what kind of clinics do this? Like, is there some sort of resource available,
Yeah,
or?
I think the only thing really to do is to really call each clinic and ask them. I know specifically there is one in Alberta that will do it. It's in Calgary. I don't know the name of it. I went to a talk a year or two ago, and they described the full process and everything, the pretending and whatnot. So they know the process. I think labs are hesitant to do it because it puts them in an awkward situation too of knowing information that is not given. And there's always the possibility of a slip up, somebody in the process saying something when they shouldn't. And so it's probably that is why they're more hesitant to do it in general, but technically it's available. The clinics just might be more hesitant to do it. And the only thing I can think of is literally calling each of the clinics to ask them. I don't know any specifically in Ontario. I know that we've had a couple go to LifeQuest, that's in the GTA area, to talk about it. They decided not to pursue it, but they were talking about non-disclosure genetic testing as well. So they didn't tell me that they wouldn't do it, so that's my only suggestion at this point. But I do know one in Calgary that for sure does it.
Yeah, I found one in Calgary.
Okay.
I also found one in Vancouver, but I only found the 2.
Oh, okay. Nothing in Ontario.
Yeah, Genesis, and they seem to be pretty open about it.
So
So one
what
in
are these-
Calgary was actually very enthusiastic as well, but the rest of them are just very much on the fence. And then I found a few in the States. So if you're paying for it, I mean, why not go
Which
to
is,
the
yeah.
States anyway?
So the Genesis one, I was just going to say, is those 5 labs that I mentioned all work with Genesis.
Oh, okay.
So they were maybe able to do it, given that your experience that Genesis does it.
Gotcha,
So
okay.
those are the 5 clinics that I know work with them.
I was going to make a comment. So wherever you live, the cost is, like, I don't know where you live. If you live in Ontario, or if
Yeah,
you live
I'm
out
in Ottawa, yeah.
yeah, like some people would really have to travel really far
Oh,
to
yeah,
get this
yeah,
done.
and
there's that
yes,
added cost.
absolutely.
Well,
Yeah, I fully
originally
acknowledge
when
that
we
too.
were going to get it done, the only place was in Montreal, and we were going to have to fly to Montreal to get the cycles and do the treatments, and we lived in Vancouver. Then Genesis started doing it, so we went to Genesis.
So maybe what we'll do is we'll get.
Well, let's introduce them.
Yes, that would be great.
That was a great segue. They're already speaking up anyway. So thank you very much, Sonia. That was great, but you'll be part of the
Yes,
question and answer
absolutely.
too, right? So I'd like to introduce you to, if you haven't already met Megan Carroll, I'd like to introduce you to Megan Carroll and Mac Erno and Stephanie Reese. These 3 individuals have all been through the process, yet none of them are married to each other. I want to make that very clear. I did not make that clear before, and assumptions were made. That was my mistake for not doing clear
My
communication.
husband.
So these individuals have been through it. I'll let them tell you their story, if you don't mind, rather than me say it. And then you've got a lot of experts here to answer questions. So go there. Go ahead, Megan.
Oh, okay.
Fire away.
So
Just a 2-sentence on your story.
I
If
guess-
they haven't seen, do you already? Yeah. Do you really want to know?
So I guess it was 2002. No, wait. When did we have the babies? 2006. So when Jeff got the diagnosis, we were convinced that we were not having children. Like PGD was not even an option at that time. And Jeff, being the person that he is, was always sort of like knowing what science was going on, what was going to happen, blah, blah, blah. So as soon as it became a presentable option, we started looking into it. We started looking into clinics in the States, we started looking into clinics in Canada. And at the time, there was only 2 doing it in Canada. There was the one in Montreal. And then sort of like right at that same time, Genesis in Vancouver started doing it. So that's when we decided that yes, we're doing this thing. So we had a successful PGD first time, and I have twins, Billy and Elijah, who are now 6 years old. Slightly more than 2 sentences.
No, you bet. Yeah, absolutely. You want to go?
Go ahead.
You want me to go? Okay. So yes, my name's Mac Erno. I live in Alberta. I live near a city called Grand Prairie. My wife is gene positive. We got a genetic test on her to find out for family planning. That was what drove us to get the test. So yeah, we've been through 2 rounds of PGD. And some of you may have seen our story. There was an article printed about us in the Horizon, I believe. And so you may have seen part of our story there. So I won't go into all the details for sure, but I'll tell you a little bit about it. So we also used Genesis in Vancouver. And So it was quite a distance for us. So the travel, the thought about travel cost is very real. We live in northern Alberta. It's about a 15-hour drive. So sometimes we drove and sometimes we flew. But it is quite a trek. Both times we did the round, our different cycles. We spent, Amanda was there for close to 3 weeks each time. And I was there for at least 10 days each time as well. So it was a real commitment. It was certainly a financial commitment and a time commitment and, that we went through. But so our experience was, I guess maybe I'll start off by saying that we think it's an amazing technology and we really support it. And we don't regret going through it. And I'll tell you that we did 2 cycles and we didn't have success. And I'll tell you a little bit about that. But we do think it offers something amazing, and we think it is a fantastic opportunity, and we certainly don't regret that we did it. But it wasn't successful for us. So we did have 2 rounds. The first time we ended up with 6 embryos that we sent off. 5 came back that they carried the HDV, and 1 did not, which we implanted that one, and it did not take. So 5. This is a really long story. I'm compressing it quite a bit. But 6 months later, we did another cycle in Vancouver. So we weren't daunted. We said, well, let's go do it again. And we went back and we ended up, for a variety of reasons, with 2 healthy embryos to test. And the clinic did recommend at that point that we could put those 2 on ice, freeze those 2 embryos, and do another cycle. That was their recommendation. There would have been more cost to still do another cycle, but it wouldn't have been a complete cycle cost, if that makes sense. So there would have been, the cost of the cycle in Vancouver would have still been there, but the initial, or the genesis cost, because we would not have them do the same thing twice. So we would save somewhat on that, although there would be an additional cost. So we found ourselves in a really tight spot, having to make a decision in a short amount of time because the embryos were developing and we had to decide what to do. We decided to go forward, so we had those 2 embryos, and again, this is on round 2. We had 2 embryos, so we sent them off. 1 came back positive for the H2 gene, and the other one came back inconclusive, which threw us for a loop. We went, inconclusive, I didn't know that was an option. What does that mean? And it basically means they weren't able to determine whether it had HD or not. So we had another difficult decision of what to do at that point. So again, long story, but the end result was we decided to implant that embryo, and it did not take either. So we found ourselves in a real tough spot. Boy, after going through this cycle, and now we have an embryo, and by implanting it, we are in the same position we would have been if we would have done this the fun way.
IVF is not fun.
Yes, so that's
Don't vote.
Yeah, and
it's
that's
not fun.
Yeah, there's certainly no romance about IVF. It takes that right out of it. But it is, I mean, it does offer something amazing, and it does take a big commitment. I mean, just as a bit of an example, after we did the egg harvesting on the 1 round, we went back to the hotel and Amanda slept for 12 hours straight, right through the day, which was completely uncharacteristic for her. I mean, she was exhausted. She produced 20 eggs and so I mean, while it is an amazing process, it's nothing to take lightly for sure. It's a big process. So the end of our story. I was going to comment on as well the other options in the family planning that you talked about, Sonya, there. We considered those at length when we looked at our choices after the Amanda carried the HD gene. We considered what was it?
Prenatal diagnostics.
Yeah, the prenatal diagnostics. Yeah, the different options. And we looked at that, and I was quite in favor of that. I said, well, that makes a lot of sense. You know, we could, because of the travel and the cost and everything, we said that might make sense. And we considered it for a while, and then my wife came to me and said, you know, I was an embryo once. And I was at that stage, and I carry that gene, and I'm sure glad nobody terminated me. And I didn't have a response to that. So I said, I'm sure glad nobody terminated you too. And that pretty much put that off the table right there when she came back to me with that. And I mean, and it might make sense for some people, and we still considered that for a while too. And we decided that we would have a hard time, even if we did find out that embryo carried the HD gene, we would have a hard time terminating it. So that was just for us. That was our choice. We did decide to go forward. We do have a 1.5-year old little girl, and she has a risk, which is tough, but it's certainly nothing we would trade. And we have another one on the way. Sorry. So, I mean, that's our story. We have a 1.5-year-old little girl. My wife is due in January again. And we decided not to let that stop us, which was another very lengthy and involved decision that we made. And certainly for us, we take a lot of hope, and we're very involved with the Huntington Society and do a lot of fundraising, and we very strongly believe that there will be not a cure necessarily, but a treatment. Will be something very positive by the time that our kids have to worry about it. It may not be in time for Amanda, but we're confident that by the time our kids are there. So that was a factor in our decision. I don't know if that throws more confusion into the discussion or not. Yeah. So I think that's our story. Yeah, you bet. If there's anybody has any questions, please feel free. If you want to go, Stephanie.
Stephanie and then questions.
So I'm Stephanie, and I'm from Calgary, and I just did my first round of PGD this summer, July and August. It was about a 2-month process, and of the 9 embryos that were tested, 1 came back unaffected. I think 1 was partially affected, and 1 had no DNA attached to it. So when they pulled that 1 cell out, there was just no DNA there, and there's risk of that. They implanted the 1 embryo, and we waited the 2 weeks, and it came back that I was pregnant. And they do follow-up blood tests to make sure that the embryo continues to grow, and in our case it didn't continue to grow. It just stopped, so I ended up going for an injection that they had to give me in my back to evacuate the rest of the pregnancy. So, you know, there's risk of all of that happening. You go through it, you get the ups and downs, and then you do get the bad news. But we're ready to go for a second round here in a month. And we're hopeful, you know, just like Matt. It's quite an amazing process. And I think the only barrier right now is the financial barrier. That and what it does to your body. And emotionally, the roller coaster that you go through. But it's worth trying again, in our case.
Okay, questions? Got a lot of experts here now.
I have a question for you, actually. The other 2 told us about their success rate. It sounded like 1 and 1, like an embryo without. What was yours? Did you have 2 or 3 that they were able to implant, or were they?
Oh, we had exactly 2 that were unaffected, and I think we had, like, the whole process seemed to be like a 50-50 process all the way through. Like, they harvested something like 22 embryos, and then by the time that they actually, you know, get to being able to, like, once they divide to find out which ones are viable and which ones aren't viable, that sort of like eliminated half of those, and then by the time that they do the biopsies, you know, another half are, so I think it ended up like with 2 viable, like 2 with HD and 2 with not. We did the sequencing, I'm pretty sure we did the sequencing, not the, because like we were, as we understand it, we were like the first successful Canadian IVF for PGD in Canada. So we were sort of like on that, this is a new thing that you could do, and we went for it, we did it. Saying that, and now knowing all the risks and some of the other people's stories, and I've had lengthy conversations with people on email and Twitter and on telephone calls from people saying, like, what is this process like? Now I know that it's not that simple. I was actually very cocky at first. I'm like, I have 2 babies, you put 2 babies inside of me, I'm gonna have 2 babies, like, end of story. But now knowing all the other things that go along with it and chances, and you know, I'm amazed. I think I'm very lucky, and I'm very thankful that I now have 2 children.
I felt the same way, even having 9 embryos sent off for testing. You know, we had hoped for multiples, and I just thought at least 2 are going to come back unaffected. We're going to get 2 put in. We're going to have twins. This is great. And it wasn't till the morning that they called us and said, you have 1 unaffected. We need you here by 1 o'clock in the afternoon.
Yeah, it's like that quick. Phone
And I
call,
was pretty
you're
bummed
there.
at one, but really I should have been appreciative of one, and even at that, like you don't realize how.
How hard it is. Like
Yeah.
it's, you know, you're not just.
So you're in the same city when they say you have to be here by 1, so you guys
Yes.
can't leave that work
Oh
facility.
yeah, exactly. Like
Yeah.
you're there. Like there's.
We spent 3 weeks, my wife spent 3 weeks in Vancouver for the cycle.
Yeah.
So I live in Calgary, there's a clinic in Calgary. What they did is they ship off your one cell. For us, we use Detroit. So they FedEx couriered our cells overnight, and then they do the testing in Detroit, and Detroit faxed our clinic that morning the results. So we got a report that said A, B, and C are affected, these ones aren't. And that's when they called us.
Saying that, Jeff and I did not choose to do the amniocentesis afterwards. We figured that we've now given them as much chance and possibility that they have, and the minute risk of losing the child because of the amniocentesis was enough for us to say, like, no, you know, like this egg's now been through enough, you know, like now. So I mean, there is the small chance that Billy or Elijah or both of them are still at risk, but to us they're not.
Very good. So one other thing I was just going to mention, the percentages presented here were, I think, pretty accurate, those numbers. I think we went into ours thinking it was quite rosy. Certainly we'd seen your guys' story and heard others as well, which is great. And no, don't be sorry.
But I
No.
don't feel bad.
No,
because
but
I was quite confident.
Not at all. But it's and we'd heard lots of their success stories, and they had shared with us some of their status, their statuses for the results to date and the successful pregnancies. I think they had at that point they've done 8 rounds with PGD, I think, and all of 7 of them were successful the first time, and I think the 8th they did it twice, and it worked. And we went in with the expectation that we'd have extra embryos. We were thinking, well, you know, it'd be great if we could freeze one and then be able to come back, and it's substantially cheaper and a lots less of a time commitment as well. So that was our goal, but we found that it wasn't that way. I mean, we were happy to have one, and I mean, it could have went the other way too. I mean, I guess, and we do go back to that to say that, you know, there were 6 embryos on that one round. There could have been 5 that could have been not HD affected, and 1 that wasn't. But for whatever reason, it wasn't. So it's biology. There's a lot of variables.
Had 2 and 2, and the second one wasn't looking so promising. So they said, like, you need to, you know, decide on the second one now. Like, we're either implanting 1 or implanting 2. The second one is not going to freeze. So, like, okay.
Right.
I think also there's risks, like, and I know Mac might be able to speak a little more to this, but that you risk hyperovarian stimulation with the drugs. And I know I had started to see symptoms of that, and that can be quite painful on the female. Your ovaries are swollen, they're huge. It's quite sore. Bed rest, like you're very limited with what you can do.
Yeah, I can't speak directly to that, but
No,
No,
it
it
wasn't-
wasn't.
I know I heard about it.
Yeah, no,
Yeah,
like, I mean,
I'm sure.
my
Yeah.
ovaries were quite,
yeah.
you know, swollen. Like, they were the size of grapefruits type thing. And I felt it when I moved, and I was in school at the time, and just, like, I was having to have other people do things for me because I was not comfortable.
Yeah, Amanda was basically on bed rest, which so I can't really speak to it, but I know how uncomfortable it was for her. So certainly we have the easy part of this process. There's no 2 ways about that.
Can you just give an indication of the timing of this, like from when you kind of first went to the
Actually,
to
you're probably
Genesis or
better
something?
because, like,
So,
a lot of this is why.
I got a call last Christmas. It was literally, I thought it was a Christmas present that we had been referred to the IVF clinic. That was about a 2-month, because I think I tested gene positive in October, end of November. So it was about a month to 2 months till you get a call from the clinic. Then they have you come in right away in January for an IVF info session. It doesn't matter if it's PGD, it's an info session. From there, you have to come in for a bunch of testing. Both partners go through testing, and You get to call the period hotline once a month so that they can monitor your cycles, and when you're ready to go.
The period hotline.
Yeah, they call it period hotline. And by July, we were ready to start, so that was another 6-7 months.
Did they not give you drugs to put you on a cycle?
July 1st, they started me on, for me it was a nasal spray. I don't know how it changes, but so you do a nasal spray for about a month, and in between there you start injections. The nasal spray basically shut my system down, allowed them to control it, and then the injections was a hormone injection to produce more eggs. And when you're on the injections, they had me in every other day, and I think this is why Amanda was there for 3 weeks, because they monitor blood work, they monitor ultrasounds, they monitor the size of your eggs that are growing, all of that. And then once they implant, we found out we were pregnant at the end of August, so it was 2 months from start to finish for that.
Are you giving your own injections then?
Yes.
One more question? Thank you for sharing your stories.
Yeah, I was just gonna say thank you. Thank you for sharing your story.
It amazes me how generous everybody is with sharing their story, and that's the best way for everybody else. So, thank you. And you need to know that Stephanie had no plans on sharing her story when she walked into this room. She was walking in to give the gifts, and I said, "I'll open," and Stephanie said, "By the way, I've been through this too," and I said, "By the way, did you want to talk about it?" And good. How wonderful. And I don't have a gift for Stephanie.
You know what though? The gift was in sharing. I met Matt a year ago at the symposium, and Matt has been there. I can kind of Facebook him and just say, hey, by the way. So it's just nice to have somebody else, that extra support. And I really don't mind sharing. Maybe one day I can support somebody like Matt who's been there for me.
That's probably why she thought you were married.
Yeah. Thank you, Mac. Thank you, Megan. Thank you, Stephanie. And thank you, Sonia. And thank you, everybody, for participating and asking questions.